Good afternoon. Welcome to our program today. Our workshop today is going to be focusing on regaining control of your company healthcare costs. And we are going to be spending some time talking about some innovative strategies that are available for organizations to consider. And we have two great experts in that space who are going to tell us about some of the work that they've been doing. And then we're also going to give everybody an opportunity to ask questions at the end. But before we do that, we have a series of questions for you, as we're always trying to gather information and understand what's happening in the community. So we have a bunch of questions to ask the group, and hopefully we can get some good responses. So as it's just at 12 now, hopefully everybody has had a chance to join. And our program is going to go to, it's set for 1:30, but if the questions end sooner, we can end sooner. There's no reason to stay until 1:30. So again, welcome. My name is Cliff Watkin. I'm the chair of the HR Forum for FACNY. Our HR Forum is specifically focused on bringing education in the HR and the benefits space to our membership in the Greater New England area for FACNY New England. And our programs focus on current HR topics, and for this one today, a very current topic that's on top of mind for everyone, which is healthcare costs and where are they going, what's happening legislatively, what can we do as an organization to regain control of them. So we're joined today with two people I know very well and have incredible amounts of expertise. Joel Allenbaugh is the president and CEO at Health Access Solutions. He has been working in the benefit space for probably as many years as I have, and I'll just leave it at 25 or more. And Joel specifically has an interest and a passion for ensuring that the legislation that's going through the government is designed accurately and appropriately. He was involved in being on the committees to design the Affordable Care Act back or a bunch of years now. And most recently, he has been involved in an adjustment that has been made to some of the legislation for the Affordable Care Act, which we'll be talking about today. Pascal and I have gotten to know each other through FACNY, and so we tend to share similar interests because Pascal is the co-founder and chief marketing officer for Care to Care, an organization that is exploring and trying to bring down healthcare costs specifically through prescription drugs and utilizing the lower cost prescription drugs that are available around the world. And he'll talk today also about the work that he's doing and how his innovative strategies can help regain control of healthcare. So welcome, gentlemen. Thank you for taking the time out to join, and welcome to everybody. Thank you again for taking some time out today to come hear what's happening in healthcare costs and what some options are there for the future. Like I said, we're gonna, Joel and Pascal are gonna just give a brief little presentation on some of the work that they're doing. And then we have a series of questions for you. And then we're gonna give you a chance to ask the panelists some questions yourself. So please hold the questions until that time, and there'll be plenty of time to get through everybody's questions. So we all are very familiar with what's happening in healthcare today. The Affordable Care Act was put into place, there were significant changes that occurred. Organizations had to change, healthcare systems had to change, pharmacy benefit managers had to change. Much change was put into place with the hope that these changes would help to manage the healthcare cost increases. Unfortunately, the surveys that we've seen today have not been able to do that. That healthcare cost increases are still at the rate that they have been for quite some years. Over the years, most recently, been increasing at the 6 to 8 to 10% range. Some of them even higher. Now, we can all blame healthcare legislation and say, okay, the Affordable Care Act didn't work and there really wasn't any help that was provided. Or we could blame other factors. And it doesn't really matter, because what we want to talk about today is that we have to have a responsibility to do something about it. Leaving it up to the legislators or leaving it up to our states to do something about it, even though Massachusetts was one of the first, really hasn't proven to do things that are significant enough to not have to have and sustain 6, 8, 10% increases a year, because we know our costs for doing business or our revenues don't go up that much to cover the increases that we're going to have to sustain in healthcare. And so we feel that it's really important that today's message that comes through is about our responsibility. Our responsibility as an employer, that we need to do something. We need to do something within our organization that we can control and manage those healthcare costs. And it's not a lost cause, because there are solutions out there, and you have to just look for them and work hard at getting them implemented in your organization. So doing the same thing like we have been doing generally just gets us the same result. And I think we're all at a point now where legislation hasn't done anything. We need to take responsibility and put it into our hands to get stuff done. So when you look at what is out there, what can we do with healthcare? There's three approaches that we wanted to center on and focus on today. Employers provide healthcare to their employees on a fully insured basis. So we're trusting the health insurance company to manage the claims and manage the costs and provide excellent care. The doctors and hospital systems are providing excellent care. And together, that plan that's being provided to employees is fully insured, and we as the employer don't have as much risk in terms of catastrophic claims, because the plans are insured. The insurance companies are taking the responsibility for the catastrophic claims. The second option is the self-insured option, which some of you might be on. And that is an option where you as the employer are taking more responsibility with the ups and downs of the claim costs in your pool. But you do also have insurance to protect yourselves should there be shock claims or a couple of years of really poor claims. And then you're also including into those programs wellness benefits to try to keep health lives, try to help people stay healthy. And then there's also cost containment strategies that are included in there to ensure that the increases are more manageable. Those two plan design alternatives or funding mechanisms have worked, and they've worked for many years. And there's been lots of changes over the years. And with the Affordable Care Act, they're still working, but we're still seeing increases of high percentages, and there's really no true cost control that's being brought to the healthcare claims costs. There's just more cost shifting, and specifically the Kaiser Foundation has put out a recent study of healthcare costs increases over the last 15 years, and it's showing what the out-of-pocket costs have been over the last 5 years, there's a significant spike. They've shown healthcare premiums increasing at the 8 to 10% a year, and employees' wages only increasing about 1 to 2%. So we're shifting the costs of the healthcare to the employees through higher deductibles and higher out-of-pocket expenses. Today, we're going to talk about two strategies that are solutions that are in place today. They're new, they're innovative. They do require a big change within the organization. And the idea behind it is that it's a new way of looking at healthcare. It's not taking the same way that we had and adjusting it. These are two different strategies that put the control of the healthcare costs in the hands of the employer and the employee. The first one we call it ICHRA, which stands for Individual Contribution Health Reimbursement Account. And there's some legislation about that, which explains what that is. It's a defined contribution plan design alternative. The second alternative that Pascal's going to talk about is regarding prescription drugs. And there are ways today to take advantage of prescription drugs that are manufactured outside of the US at a lower cost and a lower price point, and introduce them into your health plan to get better cost savings on your prescription drug costs. So with that introduction of what we're going to talk about today, I'm going to turn the presentation over to Joel, and he can walk us through what is ICHRA.
Yeah, thank you, Cliff. And welcome everyone. I'll keep my comments relatively brief, but I just want to share a little bit about what an ICHRA is, starting with where it came from. So you may be familiar with the terminology health reimbursement arrangement. HRAs have been around for quite some time. They've had application in health plans for quite a number of years. And really what we're talking about is a new category of health reimbursement arrangements that came about from new federal regulations that were finalized in 2019 and took effect January of 2020. And what's unique about an ICHRA specifically is that it's another way for employers that have more than 50 employees to satisfy their requirement as a large employer to offer coverage. So I can meet my ACA required compliance requirements of offering a health plan in a different way than I have in the past. And it also sort of creates this tax equity between group plans and individual plans, because what you're essentially doing is you're providing the tax-free dollars to employees, but they're actually enrolling in individual ACA compliant insurance plans available in their state and region, versus sponsoring a group health plan, that's supposed to work for your, diverse workforce. You're giving them now the dollars and giving them more freedom to choose the plan that works best for them or their family. And I'll let you move on to the next slide. I guess the big question is, why do I need to care about this? Why should I be paying attention to this? To me, it's a little bit like, the introduction of 401ks, a number of years back, where we all had pension plans with our employers, and then this crazy thing called 401ks came out, and in the early days, we don't really need to pay attention to that. And now, of course, 401ks really dominate company-sponsored retirement plans. Tax changes really do create changes in the way we behave. And this is just another example of that. And I think, from my perspective, ICHRAs are relatively new. They're relatively novel, sort of in the benefit market. I think you flash forward a number of years and they will very much be a staple in the benefit market. And I think as an employer, understanding how these plans work, understanding how they could work for your particular organization is going to have a great deal of value, and potentially put you in a competitive position by understanding how these can benefit your organization, perhaps before other organizations sort of come to that themselves. And as I mentioned, this is a way for you to satisfy your requirements as an employer under the Affordable Care Act, but you can do so without carrying any claim liability on the balance sheet. One of the things we often talk about when we talk to employers about these strategies, if you are Walmart, you have a huge population of people, and managing something like healthcare expenses, can be done relatively predictably because you just have, sort of law of large numbers at your, to your benefit. But for most of us, we're working for employers that are not the size of Walmart. Maybe we have 20 employees, maybe we have 100, 200, 300 employees. It doesn't take too many people getting sick within a group that size for us to have a great deal of cost volatility, and we can really get that volatility off of our balance sheets and provide very cost stable and predictable health benefits year over year. It also enables us to meet our requirements without participation requirements often imposed by group health plans. And sometimes that can be really useful, especially for particular employers in certain industries where just getting employees to participate in a health plan can be a challenge. And it also sort of opens the door to do some different and creative things. I mean, oftentimes when you are contracting with an insurance company, there are sort of rules of the road, and you have certain parameters that you have to operate within. And when you start to sort of shift away from that into this model of ICHRAs, there's a lot of different things that you can do as an employer. You can get pretty creative with your benefit strategies. And as Cliff sort of alluded to in his comments, we can all keep doing the same thing and expecting different results. But if we really want to get to a different, better result for us and for our employees, we're going to need to start thinking pretty creatively. So I just want to offer just a couple of quick examples. These are some high-level numbers from some case studies for companies that we've worked with over the last couple of years with ICHRA strategies. This particular company is a manufacturing company. They're actually out of Minnesota, and spending a lot of money on health benefits, as I know many employers are, and really struggling with cost inflation. You see this 11.5% increase that they were facing in their health benefits. What this chart doesn't reflect is the double-digit increase that they experienced the prior renewal. And so they're really seeing this inflation pressure, seeing deductibles go up, seeing a depreciation in sort of value of the health benefit for their employees. And like every other employer, out there today, they're trying to attract and retain quality employees. They're a growing company, and an ICHRA model for them really helped them reduce their costs right out of the gates, while also saving employees as well. And I think if there's any message with these ICHRA strategies, there's an opportunity oftentimes for cost savings and cost predictability for employers, but not at the expense of employees, at the benefit of employees. And that's a really unique, that's a unique dynamic, certainly in today's healthcare market. And then the second case study is, a smaller employer. They do tire repair, 55 employees, but similar story. Whether you're this is a company in Maine, whether you're a company in Maine, whether you're a company in Minnesota or Texas or Arizona, wherever you might be located, the healthcare challenge is the healthcare challenge, and I think we're all sort of living that pain. And once again, this was an opportunity for cost savings for both the employer and the employee. So just a few things to be mindful for, and I'll sort of come to a close on my remarks. I'm talking very, very generically about ICHRAs. Here's this new thing enabled by regulatory changes in DC. Here's some examples of some companies that are leveraging new tax rules that came about with ICHRAs and creating some savings in their cost benefits. But as with, any sort of strategy around healthcare, I think we all know healthcare is complicated, and ICRAs can be complicated too. And there are certainly nuances with ICRA strategies. It's important to understand how to work within the ICRA regulations properly and effectively. These are relatively simple regulatory change, but it's near 500 pages of regulations to reflect it. So as is often the case in the regulatory environment, it's never simple. So you just want to make sure that you're, getting some good guidance as you sort of move into this territory, or if you're investigating it as a strategy for your own workforce. Designing contributions can be a little bit complex. I think most of us know that we have responsibilities and requirements as employers to offer health benefits under the Affordable Care Act. We also have requirements to meet affordability thresholds with our health benefits for our employees. That's a simpler sort of calculation, if you will, if it's a group health plan with a certain rate for our employees. But when you start going into the ICRA world, where people are purchasing individual plans, rates can vary based on the plan selected, the age of employees. Designing contributions with those requirements and affordability requirements in mind is important to get that right. You do have to think about, the affordability, obviously, but you also need to think about not just your, what am I trying to accomplish in terms of my regulatory requirements. You also need to be thinking a little bit about what do I want, what am I trying to deliver to my employees? What value proposition and buying power am I trying to deliver to my employees? Do I want to give them just more option? Do I want to give them more affordable options? Where am I trying to arrive? And then, of course, there are some operational, aspects of ICRAs that are unique. They're a little bit different than a group health plan. The process for evaluating an ICRA strategy, designing contributions around an ICRA strategy, rolling it out to your workforce, and onboarding your employees to an ICRA strategy, it's a little different than working with a traditional group health plan. So I say all that to say, I think there's a lot of opportunity with ICRAs. I don't think it's a perfect fit for every organization. I don't think there's probably any solution that's a perfect fit for every organization, but I think it's a really interesting model that I've seen work well for an awful lot of organizations. And I think there's value in understanding how they work, and if they could be a good fit for your organization. Just make sure that you work with some competent people who have some experience in the ICRA space. It is still relatively new in the market since 2020, but it could be a really successful benefit model for your company going forward, and well worth the due diligence.
Joel, just two quick questions. Do you mind sharing what some of that success has been in the last 2 years?
Well, for our company, one of the things I think often happens is there are regulatory changes, there are new laws that come about, whether it's federal or state. But oftentimes those things are so complicated that most of us in the real world have trouble navigating them, or they sort of happen in these public policy vacuums, and a lot of us just don't know about it. And so our company Health Access Solutions, we really looked at ICRAs and said, hey, this is an interesting opportunity for employers. They should know about it, but this could very much go unnoticed for quite some time. And so we sort of leaned in and said, let's help employers understand this model and really work with them to sort of navigate it. So I say that to say, my perspective might be a little bit different, than somebody else's perspective that you might speak to. But I know for our own company, we helped the first company move to an ICRA strategy when the regs took effect in January of 2020. And, flash forward to today, which is about 2.5 years later, and we've helped dozens of companies have membership in 29 states and growing. And now have thousands of employees that have we've collectively sort of helped move to an effective ICRA strategy for them and for their employers. So it's a growing model, and I think a lot of employers are really desperate to find better ways to manage their health benefits effectively, and this could be one that could work for you.
And I'm sure some of the people in the audience are thinking, okay, well, Cliff has spoken about 6, 8, 10% healthcare cost increases. Do you have any sense or that you feel comfortable sharing with the group as to what they could potentially experience with an ICRA strategy?
Yeah, and I think, there are different strategies with ICRAs. So I'll put that caveat out there as well. Our particular model that we work with leverages ICRAs, but it's not ICRAs sort of in isolation. But our particular client base, we've seen, first of all, we've seen 100% renewal rate. So we have companies sort of in their third year in these models, and the renewal rate's been 100%. Which, relatively early days, but that's encouraging to us. A lot of companies are used to kind of bouncing from insurance company to insurance company year over year, which in and of itself can be really disruptive for employees. And we've seen cost increases year over year that have been almost flat. They've been closer to about 1% or less. So it is a model that's designed to be very cost stable, and at least in the early days, it's really been bearing out that way. So we're highly encouraged looking at how ICRAs could really be helpful for employers.
Great. Before we move on to Pascal's story, one last question, which I think might be helpful for the group, since we've talked about it, is it possible to just briefly describe what the strategy entails just from a 30,000-foot view?
So our particular model?
Yeah.
So with our model, we use a sort of a three-part solution, ICRAs being one of them, and we start with a preventive primary care base program for all employees. And one of the things we found over the years is that, if you want a healthy workforce, we need to have good primary and preventive care foundation. And a lot of people don't get recommended preventive care. A lot of people avoid and delay care. And so we try to put a base program in place that really makes primary and preventive care affordable and accessible for all employees. We sort of start there and then use a combination of medical cost sharing memberships and traditional programs through ICRA to really give employees that are sort of in different orientations with their healthcare utilization to be able to find the most cost-effective, sort of programs that make sense for them and their respective family members. So we're kind of pulling a few things together in our particular model, but it works very effectively. And I think it's important to think with any strategy, what's the value proposition for our employees? And I think sometimes we forget what we're trying to accomplish with health benefits, and we look at healthcare through the lens of health insurance, and sometimes forget that what we're really trying to accomplish is providing good quality access to care for employees. And sometimes we don't always achieve that, through our traditional approaches. So we try to get a little bit creative.
And that's what I think I'm hearing, is that the original objective of organizations providing healthcare, so they're providing healthcare to all of their employees, and the ICRA strategy allows you to do that. While you may not be providing the same level of care for everybody because it's a choice, at least as an organization, you can be you're providing health and wellness benefits, primary care benefits to your whole population. And that's, I think that's really achieving what organizations had set out to do, which was provide healthcare for their employees. So thank you. Yeah, that's great.
Yeah, thank you.
Another solution that is out in the market today is regarding prescription drugs. And Pascal has been working in this space for some time. And we'd love to hear from you. What's behind your possible solution?
Thank you, Cliff, and welcome everybody. It's not new. I'm not talking about anything new. You said earlier that you introduced earlier about new strategies. I must humbly admit that in our case, it's not really new. It's just not known. That's different, right? So the solutions that we have been implemented and pushed and promoted over the last couple of years are really not that new, but we want to make sure that people are aware and can take advantage of them. And given that, as you said in the first, as indicated in the first bullet point, we have a freaking RX price or prescription drug price issue, and that is making untenable some of the plan situations in the US. And as you said in your introduction, one of the measures that have been taken by employers so far has been to push or to shift cost more and more to basically employees, right, to say the least. Not to insurance, but to employees, right? So employees are paying more deductibles, are paying more co-pays and co-insurance and so on and so forth on not just medications, obviously, on the entire package, right, on the entire pharmacy benefits, medical benefits. So we are looking at that. We have been looking at that from the standpoint of how can we help employers and their plan members, right? So employees, to get by that and to find better, more effective solutions to reduce their cost and contain the pharmacy part of their plan. The pharmacy component of a plan cost has been growing steadily. It's actually amazing. The story, when you read that story, it's like a horror story, right? So it's been drug prices have increased 250% in the last 20 years, which sounds crazy, but it's unfortunately the reality. And it's more for some drugs and less than for others. Obviously, it's an average, but it's incredible. And we have not found, as you said earlier too, we have not found real different solutions, including in the ACA, right? The ACA was a great way to have more people join the field of insured plan members, but we didn't really resolve those issues. Why? Mostly because, as typical in America, we have left the market drive the economy of our healthcare system, right? So by doing so, we are making basically leaving the decisions made by groups of people and companies like insurance and PBMs and pharmaceutical companies and so on and so forth, drive their own interest, right? Regardless of what the actual stakes are for the health of our country, right? So or citizens. So this is the situation we were 20 years ago. We are still in the same situation, unfortunately, but we have potential options. My first comment is about what you said earlier about insurance, right? We are in the field of insurance, and Joel talked about that. In the self-insured industry, or in the self-insured space, which is your second, the second category you introduced earlier on in the call. The fully insured are typically for the smaller, either self-employed or smaller companies out there. The self-insured are actually the ones that are taking the risks, and they are supported by what the so-called insurance companies, which are not playing an insurance role. Let's be clear, in the self-insured space, insurance companies or insurance carriers are simply administrators, claim and processing administrators. That's basically what they do. And they handle, negotiating with the network and, making providers available and so on and so forth, which is useful and a great tool. But they are not playing any part of a traditional insurance role, right? And there is only a little piece of the insurance with the high risk, right? With the stop loss, what's called the stop loss insurance that are taken to prevent catastrophic losses if that happens, right? So we are not in the insurance space. We are in the self-insured space. And that starts at as low as 100 employees typically. The average would be much higher than that, maybe, probably. Typical numbers are, for self-insured employers, I'm sorry, would be 300, 500, 1,000 employees. That's where you find most of the population of employers plan, self-insured employers plan. And what has been happening is that since 25 years about, PBMs were introduced in that industry to try to negotiate on behalf of plans to get better deals and better prices and better access to medication to plan patients, plan members. Unfortunately, given the premises, the prior topic that I mentioned, which is the market, PBMs have grown and grown and grown and have, given ways to a market-driven strategies, right? Which is undoubtedly helping to grow prices instead of helping plans to contain their costs. It has gone the other way, right? So the numbers you mentioned, 6 to 8% typical, or 6 to 10%, even sometimes 12%, double-digit increases, have been the same in the sphere of self-insured pharmacy plans, and we are trying to promote different aspects. So the first thing I want to talk about is where we started, and we started that is it 4 years ago already? Yeah, 4 years ago we started promoting access to international pharmacy programs, and by doing so, we are giving people, meaning employees, personal, individual, we give them access to drugs that are priced at a much lower cost in other countries, namely Canada is our main source, of course, very well known for that by a lot of people, but also the European Union and other what's called by Congress tier 1 countries such as Australia, New Zealand, and the UK. And by doing so, we can help plans to reduce the cost significantly, and also we can achieve 2 other benefits for people, for individuals. The first one is that typically these programs are associated with no co-pays and no deductibles of any kind, because everybody's benefiting. So you want the plan to incentivize people to adhere to these programs. So they have no out-of-pocket cost. The second benefit, and it's probably the most important, is that it helps adhere to treatments, right? Treatment adherence and still is a major issue. It's been called by multiple experts, like the Kaiser Foundation that you mentioned earlier, or the HCCI, or other companies such like that. It's been called a ticking time bomb, right? So not adhering to your treatment is actually going to get your health situation worse going forward in the near future, or in the future. And it will eventually get to a point where you will be more absent, you will have more severe diseases that are more costly, and so on and so forth. So we want to get people to follow their treatment, get their medication as soon as they can, as prescribed by their doctors, and so on and so forth. And by giving them access to a zero copay, cheaper drugs that are available out there from other countries, we are helping to resolve that situation. It's not the silver bullet. Obviously, we cannot resolve every single aspect of the pharmaceutical situation or the pharmacy plans, but we can help a great deal with these in personal importation programs. What I want to say is that it's a decision that is, as I said earlier, it's not new. it's been over 20 years now that these programs are available out there. But there's been a lot of companies that started in that area, and it's been, limited to a smaller number of reliable companies that are doing that, accessing through of international pharmacies that are licensed and, with brick and mortar facilities and so on and so forth, with licensed pharmacists, diploma pharmacists, taking care of checking prescriptions, checking the health questionnaires of patients and so on and so forth. So all of the safety is greatly taken in account, and that's a very important point for us. So it's a very efficient sourcing. It's a moderate cost, as I said, not just because the price is lower, but also because we typically the guys that are sharing the same values as we do, and we choose our partners based on that, are not greedy and are trying to make money, obviously, as they should, but with the philosophy based on the principle that we make money when we actually save money to the plan. So our fees are based on the savings, not on the volume. And second, we are paid only by the plan, right? We don't receive any money by pharmaceutical companies, by brokers, or any kind of other providers. So that's the type of deal we want to make sure that people understand. And as I said earlier, and as you said in your third bullet point, plan sponsor can regain control, because when you're self-insured, you make the decisions, right? And you have to make sure that you make the right decisions for your plan members. What's interesting is that the fiduciary responsibilities of plan sponsors is at stake here, right? Because particularly in light of the new laws that have been passed in 2020 and 2021, you want to make sure that your fiduciary responsibility cannot be attacked by people, right? By employees or by other groups. And you want to make sure that you make the right decision in the interest of the financials of your plan, including your pharmacy plan. And making those decisions includes considering, investigating, making decisions on these cost containment solutions, right? Finding alternative funding programs like the ones we are promoting.
And I think what might be on some of the folks' mind who are listening today has to do with, what is this idea of purchasing prescription drugs overseas look like on the street? So when I say the street, I mean from the employee's perspective. So could you just walk us through, an organization decides to include this strategy as part of their healthcare plan. Could you just share how it works, or how different it is than a traditional health plan where the employee gets the medication through a PBM?
Sure. Actually, both are compatible, by the way. So you can have a PBM and an international mail order pharmacy program. But sure, when probably the best way to answer your question is to give you the example that we had earlier this year in March, when we onboarded a new client. We started that new client with one individual that had a specific problem to source a medication, and they needed that medication, and it was very expensive. The plan was considering carving out that medication from the formulary, meaning excluding the medication altogether, right? So we had the call with our partner, and we said, okay, well, it's easy enough. Let's do it on an individual basis. You don't have to adhere as an employer if you want to start like that. Let's do this on an individual basis, and I'll have a call together with the patient, with our pharmacist, and we will register the patient with our international pharmacy, and we will make the drug available. That's, assuming the pharmacy, the order is paid, obviously, but assuming the order is paid, we will make the pharmacy available and we'll ship the order, the prescription to the individual. So we did. One morning, we had that call, the three of us on the line. We registered the patient individually. We went through the health questionnaire with the pharmacy at the other end of the line. We could do that online, obviously, but as it was the first time, everybody was comfortable to do that on the phone. And then in 15 minutes, maybe, everything was done. The order was placed. The savings was roughly 50%. So it was a $10,000 medication per month, right?
Wow.
The patient is still on that, right? It's the fifth refill that we're doing right now, I think. So instead of instead of $20,000 or $16,000, we billed that $9,000 or something. And we came back. We went back to the employer saying, hey, we've done the registration. The order is placed. You just if you want to communicate to the entire workforce, fine, great, we will support that. If you just want to do it individually, just pay the order, transfer the money, and we're all set. And it's been 5 months that this individual is receiving their medication, their expensive medication, safely in their mailbox individually. So it doesn't go through us. It doesn't go through anybody in the company. It goes directly from the pharmacy to the patient, and of course with the control of the doctor, the medical doctors, both sides in Canada as well as in the US, of course. So it works. And the comment, it's interesting because the comment of actually the wife of the patient was on the line with us, and she's taking care of her husband. And she said, wow, I've been trying I've been going through a lot of these online programs and, accessing different healthcare systems and so on. And it's been the easiest, quickest, and most effective enrollment that I've ever seen, right? So it's reasonably easy. It doesn't require, a 100-page contract to be signed or anything like that. We are not in the business of feeding lawyers. We're just trying to help people, right?
Agreed. And I'm glad to hear that it can be done on an individual basis or part of the whole health plan. So that's great.
Absolutely.
Thank you, Pascal. So we've come to the end of our formal presentation about these kinds of solutions, and getting back to some of the comments we made at the beginning of the presentation, which is as an employer and as an HR professional or a CFO or a CEO, whoever's has some responsibility regarding healthcare costs and healthcare benefits that are provided to our employees. We have that responsibility, and we have the responsibility to seek out different solutions that are not standard, or we don't just take the ones that are fed to us based on the knowledge of the individual who's presenting it. So we wanted to ask from the audience, and we have a nice group of people, based on what you've heard today, that there's 2 possible solutions that you could take advantage of. Are there any others that you have seen around healthcare benefits specifically that you've either sought out or has been brought to you that are solutions you're either considering or you've already implemented? We'd like to know if that is some information that you have available. And if you could just, somebody put something in the chat, or you could raise your hand, and then we'd love to hear from you. Great. Rosamunda, please go ahead. Let's hear from you.
Can you hear me?
Absolutely.
Two things. Thank you for the presentation. One, can we get a copy of the slides? And two, the chat is disabled.
Oh, okay. I think we can turn that on.
Thank you.
Sure. And the presentation will also, and the recording will also be on the FACNY website. So that's available for anybody. Great. Anybody else want to share some solutions that you might have had experienced or you're looking into? Okay, so two people raised their hand. Who's the second person? All right, I think just okay.
Chat is working.
Yeah, the chat's working now. Great. All right. Well, the second question that we wanted to ask, Philippe. Great.
Yes, hi, Philippe, and everyone. Thanks for your contribution. Good discussion. Yeah, I was wondering. I think I had we had talked before about potentially like performing surgery in countries where healthcare providers charge much less, so that it would cover for not only the cost of the surgery but the travel expenses and accommodation expenses associated with the procedure. So I was curious about whether this is a trend that is growing, or because I know, Pascal, you were working a bit in that area at some point, so I'm curious.
Yeah, Philippe, thank you for that. I may jump in right now. Yes, we actually started with this idea. That is actually a great point that you're making. Of course, it's not limited to medication. We started from medical travel, and we know, most of us know, that medical interventions and services are cheaper in most other countries, particularly in Europe. Unfortunately, we stumbled on two main issues. One main issue is that particularly for significant interventions such as open heart interventions, or major surgeries and so on and so forth, people don't want to travel too far from their family, so it's not really the best option for most of them. At least there's still a market for that, but it's not the best option. The second problem associated with that was that we realized a little bit late, I must admit, but we realized that most Americans don't have a passport, which is a major issue when you want to travel abroad. So it didn't go very well initially in that direction. And the second major hurdle that we found back in 2019 was the COVID, right? With the pandemic, you obviously couldn't do anything really travel wise. So that kind of at the end of 2019, we were already working on the pharmacy side, and we actually launched it in 2020, right? So that was the end of our medical travel experience. I'm not saying we will put that to rest forever, but for now, it's on the back shelf, right?
I would add too. I have seen some international travel. We've seen a lot of discussion about international travel, and I've also seen a lot of domestic travel for surgeries.
Absolutely.
Which there's a lot of, actually, and I think a lot of people don't realize that there's pretty significant cost disparity just among providers within the U.S. And one that jumps to mind is the Oklahoma Surgery Center.
Yep.
That sort of has a independent surgery center, has quite a reputation, and has people traveling actually from other countries to their center for surgery. But also, I know a number of self-insured health plans that will cover the transportation costs for their employees to go have surgeries there from all around the country. So I do think that people are starting to realize that, hey, I'm not restricted to my immediate geography, and sometimes there's advantages both in terms of cost and quality, to consider a bit of travel.
Sure, absolutely. That center of excellence, like the Oklahoma Center you mentioned, and others, have been growing over the last few years. It's actually a great option for many plans if you want to take the time to put that together and inform your patients, right? The members have to be informed and make, they make the final call typically, right? So you want to make sure that it's not forced on anyone, but explained, right?
And before we go on to the next question, I just wanted to share one thought that came to my mind, and that is with the recent changes around abortion and individuals now having to go find alternatives because their state didn't provide for it. It is also a slight door opener or a slight different way people are thinking about how they're going to get healthcare, because before we're used to getting healthcare and just going to somewhere locally to get it done. And now that's been taken away. And so people have to think about getting their healthcare from another location.
Absolutely.
So Matt Pupil, you had raised your hand. You have a question. Go ahead.
No, hi. Yeah, this is Matt Pupil. I appreciate the opportunity. A lot of what's just literally been said, what was on my mind. I know you were talking about domestic versus international tourism, we call it, where you seek care either out of the country or at least out of state. And the Supreme Court Roe decision, the recent decision, has brought to light the domestic tourism part more so than anything in the past decade, I'd say. Other areas, though, that we find can assist with some of this is a lot of the carriers, and it's usually the BUCAs, Blues, United, Cignas, or the Aetnas, are also offering what are called limited or narrow networks, which are essentially networks which direct members with higher cost claims to use certain providers that are lower cost and drive higher quality results based on data and outcomes. And we find that typically could drive some significant savings as well. So I think the point is there's a lot of tools that are available today from the vendors, typically the larger vendors and some smaller ones as well, that can really help lower costs at point of service, drive quality, and the communication that employers can provide to their employees and their members, I think could essentially drive a higher level of understanding and appreciation of what's being provided to them. And I think that's one of the biggest challenges is your employees, your members, they might not realize all the work that you're doing, all the accomplishments you've made to get where you are today with the networks, with the providers, with all the decisions that you've made. And the communications is a significantly large part of any successful strategy or plan that you roll out. For my 2 cents.
Thank you, Matt.
Sure.
I appreciate it. We're starting to get a couple of questions in the chat. I'm going to hold those off until we just move to the Q&A section, so I can just quickly get through some of our questions that we wanted to ask the audience. This one will be quick. If we could just see a raise of hands of anybody who heard about the prescription drug program Pascal spoke about, or Joel talked about regarding ICHRA. Has anybody heard about these strategies or looked into them before? Okay, great. Thank you. The next question that we wanted to hear was that answers to was around talent. So today, many of us in organizations are struggling to find talent to come fill the positions that we have available. And in the past, 15, 20 years ago, employers would do whatever they could to upgrade their benefits program to attract talent. And that could be a component of the benefits program having to do with time off or 401k plans or retirement plans, whatever it was, and insurance plans. And that kind of fell by the wayside for quite some years. And now we have a tremendous shortage of talent. We want to know what can we as employers do to help improve benefits programs so that they can become more attractive. If anyone would like to share some of the things you're doing in your organization that's helped and been innovative to make the benefits programs more attractive. Okay, I think we have a raised hand here, and that is, oh, Matt, that you already, are you sharing that, or was that for your last question?
Oh, sorry, that was the last one. But I do have, I guess, one comment I could just add, if it would help, is what we're finding a lot of employers doing, and again, they are looking for ways to make it more exciting, make it more interesting, make it more engaging. You know, and it's been around for years now, is on the voluntary benefit side, and there's a lot of unique voluntary benefits that employers are offering, which essentially pay employees to go to the providers, which makes it a no-cost service, which typically could be, if it's communicated correctly, a good benefit offered by employers. Gets employees to the provider, gets them to the preventive care. And essentially they get a check back at the end of the day for doing what you want them to do to begin with.
Sure.
I guess that's one solution, as well as everything around wellness and trying to be creative around wellness programs, and funding some of those wellness programs to essentially provide funds to employees to make those better decisions. You know, the carrot approach, if you will, versus the stick, as I say.
Sure.
At least that's what we find a lot of employees respond to.
Great, thank you. Anybody else made any changes or considering making changes for your upcoming open enrollment in the benefit programs? So the next question we have has to do with change, and both of these programs or strategies that we've presented do require a significant amount of change, a significant amount of education. It affects the culture of the organization. It touches everybody within the organization. So there are a lot of changes that's going on. And typically what happens is, in an organization, the HR folks rely on the benefits folks to help educate, implement, and make the change. What's interesting, though, is that HR can also be very helpful in this process because they can help with the change management that's occurring in your organization, and support the work and be the communicator with your employees about the benefits program changes. We wanted to know, with these two significant changes, what type of appetite does your organization have for making a significant change like this? Anybody want to share?
Can I complete the question, Cliff?
Yes, go ahead.
It's also the appetite of the consultants and advisors, the benefits advisors, right? So I'm interested in understanding from the audience if they have heard of or if they have asked their benefits advisors about new innovative solutions, right? And what the reactions are, right? Because we know that there are a number of advisors and brokers that don't want to take any risk and don't want to change anything, right?
So just to rephrase the question, anybody want to share an experience where they've asked for changes or solutions and haven't heard any, or been directed in another way. Great, thank you. No answers does not mean this is bad. These are tough questions, and we're just trying to prove the philosophy that taking things into your own hands and taking the responsibility of doing something different for your employees is very difficult. And we agree with you. All the no's we're getting is a lot of the reasons why there hasn't been any change. And I'll leave the last question, and then we'll go back to everybody else's questions. And that has to do with the idea of getting prescription drugs in a foreign country has, in the past, been looked upon as being taboo, not the right thing to do, for whatever reason. And we don't have to discuss the reasons, but there just hasn't been a positive light around that. Would anybody like to share their perspective on telling their employees they would have the opportunity to get prescription drugs in a foreign country? How would that go over in the organization?
Do you want me to give my perspective, Cliff, or not quite yet?
Let's see if
want the
anybody has a perspective, but
Okay.
if people don't, then yes, absolutely. Go ahead.
Well, there has been it's the legal situation with importing drugs. I can debunk the problem very easily because it's been recognized since 2003 by Congress as a personal right, and it's been confirmed a few times actually. But it's as recently as 2018 in the opioid bill, buried actually, I would say buried in the heart of the opioid bill, there was basically a provision that was saying, telling the FDA, hey, if people want to import for their personal consumption drugs that are FDA approved from abroad, leave them alone. That's perfectly acceptable. And we all know that we have a price issue in the US, so let them do that. And that's where, remember that probably everybody remembers the buses that were crossing the border to get the insulin loads in Windsor, Ontario, and so on and so forth. So since then, it's been absolutely recognized and accepted by the FDA and the CBP at the border that for FDA approved drugs, prescription drugs, it's absolutely fine to get your personal consumptions imported, right? It has to be on a personal basis. Otherwise, if you want to resell drugs, that's a different story, because then you become a wholesale dealer and you need a specific import license and so on and so forth. So it's a different business. We're not talking about that. We're talking about personal right to import your own consumptions. And I see the question in the chat says, are there legal restrictions? Yes, there are restrictions. First of all, you cannot import a drug that is not FDA approved. Whether it's the same name or different name doesn't matter. It has to be approved as manufactured, as defined by the manufacturer. The differences in names don't matter really, and FDA has nothing to say about that. And the other thing is that you cannot import more than 90-day consumption, so 3 months worth of your prescription at once. So every 3 months you can refill, obviously, with your renewed prescription. And there are other considerations that are more about safety. For example, it's difficult. It's not impossible, but it's difficult to import temperature control drugs because of the nature of the shipping, which doesn't allow for controlling the temperature. So, or it's difficult to do it. You can do it, but it's difficult. or obviously scheduled drugs, right? And for those of you who don't know what scheduled drugs are, it's these are the drugs that are on a list that are specifically controlled by either hospitals or law enforcement agencies, right? So like opioids is a good example of that. You cannot personally import opioids from abroad. But besides that, that leaves a good 20, a good, depending on which plan, but the last quotation I've done last month, it was about 20 to 25% of the pharmacy formulary, of the pharmacy cost that you could potentially import from abroad. So it's a lot of potential savings, basically.
That's very, very, very high. That's good to know. Thank you, Pascal. That brings us to the end of our questions that we have for you. We have one question in the chat that somebody has raised. Daniel, thank you for raising this question. Daniel's looking to get some feedback from us as to what's an average employer contribution to the healthcare plan that we've seen in the marketplace today. 60%, 75%. Joel, Pascal, who would like to answer that?
I'll give you my best non-answer, which is that I've been asked that so many times over the years, and I see an incredible variation from employer to employer, from industry to industry. It just varies. Maybe Pascal, I don't know if you're aware of some average that's kind of aggregated in some report around the country that might hone in on that. But my personal experience has been that it's all over the board.
It is what I've heard, and there's a survey actually on that. I don't have the numbers on top of my head, but there was a survey recently. But what I know is that in the self-insured space, these employer contribution has been increasing lately after a significant decrease over the years in the 2010s or so. It's been increasing precisely because of your point, Cliff, to attract more talent. And
sure,
if you want to attract talent, one good way to do that is say, hey, you have a good benefits package and you don't have to pay a dime, right? So that's kind of the deal. It's not, of course, available to everyone because it's very expensive, but people are starting to get there slowly. That would also mean that if you could cost contain some part of your plans, as we discussed earlier, then you can make that money available to improve the contributions to your plan, or to make different balancing decisions over the cost the cost arrangements in your company, right? You can take a piece of that and make it available in forms of incentives or salaries or whatever, right? So it's a very interesting equilibrium exercise that we're looking at right now.
And a similar question that came in from Philippe around contributions has to do with the underlying mechanisms that are giving us the cost savings within ICHRA health plan strategy. So Philippe wants to know, what are some of those underlying mechanisms that are helping to get those savings that you had mentioned before, Joel? So
it varies a little bit, and I'll speak kind of generally to ICHRAs and then maybe a little bit more to our particular ICHRA model. In some states, when you simply compare individual market premiums to average group market premiums, in some cases, individual market premiums are higher. In some states, individual market premiums are lower. So sometimes there's literally a crosswalk that you can look at to say, are these more cost effective? Sometimes it can have to do with the average age of a workforce. Individual market plans are age-based. ICHRA contributions can be age-based. And if I have a particularly young workforce, those premiums may be lower in an individual market than they are in a group market. Some may be driven by my particular claims experience for my employer plan. I have a particular employee or dependent on my plan that is has a very, very high cost medical condition that's driving the overall cost of my plan up to a point where I'm having trouble sustaining a quality benefit, I step out into more of an ICHRA strategy. It's defined contribution. My employees are in a much, much bigger pool, if you will. So all of those can be some of the underlying mechanisms that can create cost stability just within the context of an ICHRA in a general sense. Within our own program, we do some other things. We provide healthcare in some parts of our program outside of the insurance structure entirely. For example, providing access to direct primary care subscriptions for employees where we're paying a monthly subscription fee, and primary care becomes a sort of a different experience for them. They have unlimited access to a primary care physician. They've eliminated co-pays when they go in and visit that physician. They can see them more frequently. They can sort of better manage, a particular condition because of that accessibility. So sometimes it's not the ICHRA itself that's creating the cost savings. It's some of the other strategies we're coupling within an ICHRA strategy in our own particular model. But I think hopefully that answers the question. There can be a number of factors that have the potential to create cost savings. And I would also say we have done analysis for employers before comparing a traditional plan compared to an ICHRA strategy, and not always found cost savings. So it's definitely, it depends a bit on some of the dynamics within a particular employer.
Great. Thank you, Joel. We're nearing the end of the program, and I just wanted to ask if there's anyone else who has okay. I see another question. This is from Matt. With regards to out-of-country RX, how do you work with carriers to attribute the costs towards the deductible and out-of-pocket expenses? Are you able to track this data?
Yeah. Okay, so what's going on in the self-insured space is that you typically work with a carrier that is actually a PBM, a pharmacy benefits manager, and you have to carefully draft the contractual agreement with the PBM in such a way that you can regain control, which is the point of our webinar, I guess. You can regain control of your costs. So you have to make sure that you can make decisions to exclude some medications from the PBM's formulary, and you can source this medication abroad through, of course, the personal importation, as we talked about before. So you have to make sure that these provisions are part of the contractual agreement that you have with the PBM. If they are not, or if they are excluded, like they are typically excluded by the top three, the big guys, the top three PBMs, or big carriers, because they are one and the same. Typically, they exclude that. You're stuck. Basically, you have a hard time. They will allow you to do it on the margin, because it's kind of good for them to show that they can accept some flexibility and retain the contract, but they don't like it. So you have to make sure that it's part of the possibility if you have a provision in your contract that allow you to do that.
Great. Any last questions before we wrap this up today? Great. Well, thank you all for joining today. I hope this information was helpful. Thank you, Joel, and thank you, Pascal. And of course, Ludovine from FACNI for helping to get this off the ground. If you wanted to share some of this information with other folks in your organization, this presentation is going to be posted on the FACNI website, and so you'll be able to see it there and get copies of the slides, and then hear the presentation as well. So if you are a member of FACNY and you have not joined the HR forum, you can do that. That's a private group, and you can just send an email to somebody, to Ludovine or one of the contacts at FACNY, and we can add you to the HR forum group. So again, thank you all and have a great rest of the day.